Well, welcome to the arm. And before you say, I thought we were already there, remember that in anatomy, the term arm is specific. It's the region between the shoulder and elbow. The entire shoulder to fingers business can be called the upper limb, upper extremity, or upper appendage. And which of those you hear used relates to preferences by clinical specialty. Anatomists tend to use the word limb, while my PT students learn to use the term extremity from their physical therapy professors. We already know that the bone of the arm region is the humerus, but we only covered its proximal end in the last lesson on the shoulder. To understand the elbow articulation, we need to look at the distal humerus as well as the radius and ulna, at least the proximal regions of those forearm bones. The distal humerus is quite complex, and that's because it articulates with both the radius and the ulna, and for two different purposes. The elbow is really a group of three joints: the humero-ulnar joint, the humero-radial joint, and the proximal radio-ulnar joint. So let's look at each one. But before we do, let me set you up with a clinical correlation. And this is one I'm sure you can identify with, since we've all seen people do this with kids. A 2-year-old's uncle likes to grab each of his niece's hands and swing her around in a circle. But on one occasion, after he does this, the little girl holds her right arm at her side, slightly bent at the elbow and held in pronation. Remember, that's palm facing posteriorly, not supinated as in anatomical position with palms forward. The little girl seems to feel pain in the right elbow region as she touches there with her left hand. There's no obvious swelling or deformity at the elbow. So how did her uncle's attempt at play unintentionally hurt this little girl? To help answer that question, let's finish off our study of the humerus. In the previous lesson, we left off our review of the landmarks of the humerus with the deltoid tuberosity, which is where the deltoid muscle inserts. At about the same vertical level, but on the posterior aspect of the humerus, is the radial or spiral groove, approximately at mid-shaft. That's the location where the radial nerve and its accompanying profunda brachii artery, also known as the deep brachial artery, run along the humerus together. Because the groove spirals around the posterior humerus, some sources call it the spiral groove, but the placement of the radial nerve, remember that's one of the terminal branches of the brachial plexus, gives it the alternate name radial groove. Proceeding distally, the humerus has a pair of epicondyles, medial and lateral. The medial is larger and more easily felt at the elbow. Remember that medial is the side closest to the body when the upper limb is in anatomical position, and that's the ulnar side. Ulna starts with a U, and it's closer to you if that helps you remember. We'll see that the medial epicondyle is a common origin for several flexor muscles of the anterior forearm. The lateral epicondyle is a common site of origin for many extensor muscles of the posterior forearm. Now, epi means above, so you'd think that the area distal to these epicondyles would be called the medial and lateral condyles, but that's not so in the humerus. This is because it articulates with both the radius and ulna, and as I said, for essentially different functions. The medial aspect of the articular region is called the trochlea, which is Latin for pulley, since it resembles a spool. The proximal ulna has a corresponding trochlear notch that forms a hinge joint with the trochlea of the humerus. The lateral part of the articular surface of the distal humerus is called the capitulum. It's more like a rounded knob, and it articulates with the head of the radius. Capit means head, so the drum-shaped radial head, which is proximal, forms a joint with the capitulum of the distal humerus. And this forms the pivot or rotation joint at which pronation and supination occur. And though we see that motion most obviously at the wrist or hand, it actually happens at the elbow. The trochlear notch on the ulna is U-shaped to help form the hinge joint between the humerus and ulna. The proximal and more posterior end of the trochlear notch is a large prominence known as the olecranon process of the ulna. It's the large bump you can easily feel on the posterior elbow. The more anterior end of the trochlear notch is a small coronoid process, perhaps because it sticks up like the point on a crown. To complete the posterior part of the hinge joint, the distal humerus has an olecranon fossa, which serves as a deep spot for the olecranon process of the ulna to sit in when the elbow is fully extended. Anteriorly, the distal humerus has a coronoid fossa medially and a radial fossa laterally to accommodate the coronoid process of the ulna and the radial head when the elbow is maximally flexed. A fossa or notch is often named for the bone or landmark it's receiving rather than the bone it's on. The other landmark on the proximal ulna that is relevant to the elbow joint is the radial notch. It helps form the radioulnar joint by receiving the head of the radius as it rotates during pronation and supination. So the radial notch is on the ulna, which students often find confusing. Again, it's named for the bone it's receiving, not the bone it's on. Distal to its head, the radius has a constricted region called the neck, and the radial tuberosity is a prominence on the anterior aspect of the proximal shaft of the radius, while the ulnar tuberosity is a prominence on the anterior aspect of the proximal shaft of the ulna. So sometimes the landmark is named for the bone it's on, adding further confusion for students. Along their shafts, both the radius and ulna have a sharp interosseous border or crest, each of which faces the other and serves as an attachment for the interosseous membrane. Now there's an example where both bones have the same name for a landmark, adding even more to the complexity of naming. The interosseous membrane supports the linkage between the radius and ulna and divides the muscles of the forearm into anterior and posterior compartments, as we'll see in the next lesson. The ulna has a head, but it's distally placed. In fact, it's the bump you can see and feel on the back of your wrist on the little finger side. The distal radius has a counterpart ulnar notch to receive the head of the ulna. But there's no rotation at the wrist like there is at the elbow during the movements of pronation and supination. At the wrist, both the radius and ulna have tip-like extensions of their distal ends called styloid processes. The styloid process of the radius is a lateral projection off its distal end, and the styloid process of the ulna is a medial projection off its distal end. We'll talk more about the distal radius and ulna when we cover the wrist. But let's return to the elbow and consider its ligaments and the movements they allow. Since the articulation between the humerus and ulna forms a hinge joint, the elbow, like other hinge joints, has a pair of collateral ligaments. Collateral meaning both sides or mutual sides. The ulnar collateral ligament joins the medial epicondyle of the humerus to the olecranon and coronoid processes of the ulna. It stabilizes the medial side of the elbow joint. The radial collateral ligament attaches to the lateral epicondyle of the humerus. However, it doesn't attach to the radius. This is because the head of the radius has to spin around on the capitulum of the humerus during pronation and supination. If the radial collateral ligament attached to the radius, it would interfere with this rotational movement. So the head of the radius is surrounded by another ligament called the annular ligament, sometimes spelled with one N. The annular ligament not only holds the head of the radius in place, but also serves as the distal attachment of the radial collateral ligament, stabilizing the lateral aspect of the hinge joint at the elbow, while still allowing the rotation of the radius during pronation and supination. That's some cool engineering, if you ask me. So the elbow is clearly a pretty complicated combination of joints. But in terms of muscles, the arm is by far the simplest region in the upper limb. The arm has two muscular compartments, an anterior and a posterior. But before looking at the muscles, we need to first understand what compartments are and how they're formed in the limbs. Now, beneath the skin of the upper limb, we wear what amounts to a long sleeve glove of fascia. Remember, fascia is the anatomical term for the various planes of connective tissues in the body that bundle structures together and form layers in certain places. In the upper limb, this sleeve is called the brachial fascia in the arm region and is called the antebrachial fascia in the forearm. This is because brachia means arm and ante is the Latin prefix meaning before, or in this case simply for, as in forearm. Parts of the brachial and antebrachial fasciae dive deep, attaching to the humerus in the arm or to the radius and ulna in the forearm. These so-called intermuscular septa form compartments, and their fasciae also form planes in which vessels and nerves travel. So neurovascular bundles, muscles, and bones are deep to the brachial and antebrachial fasciae. But superficial to this long sleeve glove of fascia is our subcutaneous fat. And within that layer of fat run our cutaneous nerves, as well as what are called cutaneous veins. The nerves provide sensation from the skin, but these cutaneous veins lie just below the skin and are often used for blood draws and intravenous therapy. Because they relate to the metabolic needs of the musculoskeletal systems, let's take a quick look at the cutaneous veins of the upper limb. Now, veins always carry blood toward the heart without exception. And in most body tissues, veins hold blood that has picked up carbon dioxide, heat, and other metabolic wastes from body tissues. Arteries, on the other hand, always travel away from the heart. And in most of our circulation, arteries carry blood rich in oxygen and other nutrients to feed body tissues the substances they need in order to function. The tissues that make up nearly all organs, including muscles, bones, and skin, contain arteries to feed them and veins to drain them. However, the skin contains extra veins called cutaneous veins. These don't have any arterial counterparts. The additional veins serve as an extra source of blood that we can access during an emergency or exercise, for example, as a rapid way to put more blood into our skeletal muscles so we can fight or run, whether encountering a predator or simply on a treadmill. Blood isn't stagnant in these cutaneous veins. It circulates. But these cutaneous veins are sometimes called our venous reservoir because of the extra blood they hold. If we start exercising, cutaneous veins can shunt some of their blood to deeper tissues that need it. They can also take body heat, like that generated by muscle activity, and bring it to the surface to help dissipate it. That's why some people, especially those with light skin, may look flushed when they exercise. Sweat glands in the skin help cool the body by evaporating off some of that heat. These cutaneous veins can also send some of that extra blood into deeper veins if there's a sudden drop in blood pressure. That's why people may appear to lose color from their skin when they're in shock, which is a sudden drop in blood pressure that's caused by severe allergy, infection, blood loss, poisoning, or other trauma. So let's consider the major cutaneous veins found in the upper limb. On the back of the hand, we have a series of veins called the dorsal venous arch. Remember, the back of the hand is called the dorsum of the hand. Many of us can see our dorsal venous arch, especially as we age and our skin gets thin. And you may know that this network can be used in intravenous therapy and for blood draws, just like other veins in the upper limb. On the thumb side of the dorsal venous arch, the veins coalesce into the large cephalic vein. And on the little finger side, the veins of the dorsal venous arch merge to form the basilic vein. Now, the cephalic vein ascends laterally along the forearm and arm and eventually runs in what's called the deltopectoral groove. That's a pathway between the deltoid and pectoralis major muscles. Then the cephalic vein drains into the deeper and much larger axillary vein. It sits next to the axillary artery, which, if you remember, is surrounded by the brachial plexus. On the other hand, there's another pun, the basilic vein that forms at the medial aspect of the dorsal venous arch ascends the forearm on the little finger side. And in the mid-arm region, it dives deep and empties into the brachial vein of the arm. Anteriorly, in the crook of the elbow, a region anatomically known as the cubital fossa, the basilic and cephalic veins are usually connected by what's called a median cubital vein, at least in those people who are a relatively easy stick for a phlebotomist. And I know what I'm talking about there because I was a phlebotomist for a year or two before I went to college. I drew blood for several hours a day at a hospital, so whenever I have to have blood drawn, I always say to the phlebotomist, I deserve every stick I get, and so will you. Anyway, remember that these cutaneous veins don't have counterpart arteries, so there's no cephalic artery and no basilic artery. Now, let's return to the compartments of the arm and the muscles in them. The anterior arm contains 3 muscles, all of which are supplied by the musculocutaneous nerve, one of the 5 terminal branches of the brachial plexus, off its lateral cord. We've already mentioned 2 of these muscles since they cross the shoulder. Coracobrachialis, which remember originates on the coracoid process of the scapula and inserts on the proximal humerus, well, it only crosses the shoulder. It's a pretty puny muscle that weakly adducts, and some sources say weakly flexes the shoulder. The musculocutaneous nerve typically enters the anterior arm by directly piercing that coracobrachialis muscle and passing through it as it innervates the compartment. Also previously mentioned is biceps brachii, which crosses both the shoulder and the elbow. As its name implies, the biceps brachii has 2 heads. The so-called short head also originates on the coracoid process of the scapula alongside coracobrachialis. But the long head of the biceps brachii takes origin off the supraglenoid tubercle, that small bump superior to the glenoid fossa. Now, this long tendon of the biceps brachii actually passes into the capsule of the shoulder joint, which is unusual for a tendon, and enters the intertubercular groove between the greater and lesser tubercles on the proximal humerus. That landmark is also called the bicipital groove for the biceps brachii tendon it holds. A small ligament called the transverse humeral ligament, actually part of the capsule of the shoulder joint, holds the tendon of the long head of the biceps brachii in place in the intertubercular groove. Now, due to crossing the shoulder, biceps brachii is said to perform weak flexion there. Now, the long and short heads converge, and the insertion of biceps brachii is on the radial tuberosity. But part of the insertion, known as the bicipital aponeurosis, stays superficial. It reaches across the cubital fossa anterior to the elbow and inserts on the antebrachial fascia, that sleeve around the muscles of the forearm. Now, when it comes to unusual things like this superficial insertion into fascia, students always ask me why. And I suppose if there is a function, the bicipital aponeurosis does help protect some of the important contents of the cubital fossa, like the brachial artery and the median nerve, which pass deep to the bicipital aponeurosis. If you bend your elbow, allowing your arm to hold the weight of your forearm and hand, You can easily feel the biceps brachii tendon superficially at the front of your bent elbow. In terms of function, the biceps brachii often gets the bulk of the credit for flexion at the elbow, and bulk is another pun there, since one reason people think of the biceps brachii as the main flexor of the elbow is that it tends to bulk up when people train and lift weights. But biceps brachii is the more superficial of the pair of flexors of the elbow, so it's simply more easily seen. I'll also add that due to the attachment on the radial tuberosity, the biceps brachii doesn't only flex the elbow, it also helps supinate the forearm at the elbow. Consider that for any muscle to supinate or pronate, it has to attach to the radius, not the ulna. Remember, the joint between the trochlear notch of the ulna and the trochlea of the humerus is a hinge joint, so the ulna cannot possibly pronate or supinate. You can easily demonstrate that to yourself since you can feel your ulna down the length of your forearm. And when you pronate and supinate, you can feel that it does not move. The biceps brachii's insertion on the radial tuberosity helps pull the pronated radius into a supinated position. The third and final muscle of the anterior compartment of the arm is the brachialis, which only crosses the elbow. It takes origin off the distal half of the anterior humerus and inserts on the ulnar tuberosity and coronoid process of the proximal ulna. Now, the brachialis should really get top billing as the main flexor of the elbow, and that's its only function. We didn't mention brachialis with the shoulder because it's the one muscle of the three in the anterior arm that does not cross the shoulder. The coracobrachialis crosses only the shoulder, the brachialis crosses only the elbow, and the biceps brachii crosses both. Also, I'll reiterate that all three muscles of the anterior arm are supplied by the musculocutaneous nerve, and those muscles are the only motor job of that nerve. As its name implies, though, the musculocutaneous continues on as a nerve to the skin. Specifically, it becomes the lateral antebrachial cutaneous nerve. But remember that all five of the terminal branches of the brachial plexus, not just this one with cutaneous in its name, do supply some skin of the upper limb. Okay, let's return to our clinical scenario. Remember the little girl who was swung around by her arms by her uncle and wound up with a painful upper limb that she held at her side? What could have happened? I'll give you a hint. This is a problem with the elbow joint, and it results in part from the fact that the head of the radius is still cartilaginous in young children. It hasn't ossified and turned to bone yet. Cartilage is much softer than bone, as you likely know, and the ligaments in children are more lax than in adults. Have you heard of a subluxation? It's the term used for a partial dislocation. If the upper limb is stuck in pronation, what specific part of the elbow joint could be involved, since it's where rotational movements occur? If you said the humeroradial joint, you're correct. This subluxation is also known as nursemaid's elbow. It can also happen when someone yanks up on a child's arm to get them to stand up or follow along. We learned that the annular ligament stabilizes the head of the radius. And if the radial head comes out of the ligament, it may have to be manually manipulated by a clinician in a process called a reduction to be put back into place. Often the child can immediately begin to use the elbow again. But kids who have a subluxation of the radius at the elbow may be prone to it again, so please don't swing kids around by their upper limbs. This very accident happened to the daughter of one of my PT colleagues, in fact, our resident limb expert, while his child was at the babysitter. Now, let's move on to the posterior compartment of the arm, where many references say only one muscle, the triceps brachii, lives. But we'll also take a look at another seldom discussed muscle, anconeus. Triceps brachii has 3 heads. Its long head originates on the infraglenoid tubercle of the scapula, but its other 2 heads are lateral and medial. The long head is the only one of the 3 that crosses the shoulder. And there it helps stabilize and weakly extend the shoulder. The triceps brachii's lateral head originates on the proximal aspect of the posterior humerus, and the medial head originates on the more distal aspect of the posterior humerus. The radial nerve descends the posterior arm by passing in the spiral or radial groove that runs between the origins of the lateral and medial heads. Now, all 3 heads converge into a single muscle belly, and that inserts on the olecranon process of the ulna. Since the triceps brachii crosses the posterior aspect of the elbow, what is its function? If you said extension of the elbow, you're correct. And what about the innervation? Remember that all muscles of the posterior arm and posterior forearm are supplied by the radial nerve off the posterior cord of the brachial plexus. Because of the pathway of the radial nerve against the humerus, a fracture of the proximal humerus, such as at the surgical neck, can tear part of the radial nerve, causing issues with elbow extension and affecting muscles inferior to the elbow, as we'll see in our next lesson. Anconeus is a small muscle also supplied by the radial nerve, and anconeus also extends the elbow. It originates off the posterior side of the lateral epicondyle of the humerus and inserts on the lateral aspect of the olecranon process of the ulna, as well as the proximal region of the ulna's posterior shaft. Anconeus assists triceps brachii in its function, but its small belly is technically distal to the elbow joint. If you've taken an anatomy and physiology class before but never heard of anconeus, don't be surprised. As I said, it's typically not mentioned in high school or even undergraduate anatomy textbooks. Those of you who work out likely know that exercises called curls can be performed with barbells, hand weights, or pulleys to target the biceps brachii and the brachialis. And there's always good old push-ups or the dreaded crow pose in yoga to work the anterior arm muscles. While gym routines like push-downs and various types of extensions with weights or other types of resistance, those strengthen triceps brachii and anconeus. Yoga poses like cobra and all the various plank positions also work elbow extensors of the posterior arm. Whatever action a given muscle performs helps to tone it, and adding weights, including your own body weight, or increasing resistance to that action, like with a strap, will help further strengthen that muscle. Given we have some time left, we might also talk about group actions of muscles, particularly those of the proximal part of the upper limb. After all, a single movement is hardly ever caused by a single muscle. Most muscles work in synergistic groups. For example, at the shoulder, the anterior fibers of the deltoid, the clavicular head of pectoralis major, the long head of the biceps brachii, and coracobrachialis. They all cross anterior to the shoulder, so all participate in flexion of the shoulder. While the posterior fibers of the deltoid, the latissimus dorsi, teres major, and the long head of the triceps brachii all help extend the humerus at the shoulder. It's sometimes difficult to isolate a specific muscle during an action. Those who are fitness enthusiasts know that. We discuss muscles that cross the axilla to participate in adduction, such as latissimus dorsi, teres major, and pectoralis major. Remember the lady between the 2 majors? But coracobrachialis in the anterior arm and teres minor can also weakly assist, bringing the humerus towards the body. And already mentioned were the series of muscles that all pitch in for abduction, supraspinatus, then deltoid, followed by serratus anterior to torque the glenoid fossa superiorly and reach above the horizontal plane. Medial or internal rotators to roll the humerus inward include not only subscapularis of the rotator cuff group, but also the anterior fibers of deltoid, latissimus dorsi, pectoralis major, teres major. There's that lady in those majors again, since all of those insert on the proximal humerus anteriorly. And consider, in just that last example of medial rotation, those 5 muscles are supplied by a total of 6 nerves. Upper and lower subscapular nerves for subscapularis, lower subscapular nerve for teres major, axillary nerve for deltoid, thoracodorsal nerve for latissimus dorsi, and both the medial and lateral pectoral nerves for pectoralis major. You can really see some of the redundancy that nerves and muscles possess, and why a clinician might have to do careful differential diagnosis and numerous tests in a physical assessment to try to isolate a single muscle's action or attempt to figure out which nerve may be involved. And what about lateral or external rotators of the shoulder for a backhand swing, for instance? These include the rotator cuff muscles infraspinatus and teres minor, but also the posterior fibers of the deltoid. Speaking of swings, if you're wondering about pathologies like tennis elbow and golfer's elbow, those will take us right into our next lesson, since the elbow is also an important site of attachment for muscles of the forearm.